Hi guys, it's Sophie from In the Mess. Today we're going to talk a little bit more about fluids, go into some details about fluid status assessment and how to give fluids. So we're going to start by looking at our fluid status assessment. There's a few places you need to look for this information. Firstly, you want to have a look at your patient's blood tests, have a look at their full blood count, their U's and E's. If you can see creatinine and urea rising, or you can see their sodium concentration going up, or sometimes you might also see their hemoglobin going up, that suggests that someone's hemoconcentrating as they dry out, so they're losing all of that intravascular fluid. You also want to have a quick look at their electrolytes and see what their sodium and their potassium is doing. This gives you a rough idea about what the patient might need in terms of fluid replacement. Look at your patient's observation chart. You want to see their blood pressure, you want to see their pulse, and you also want to see if their urine output's been documented. This might be on a separate chart, like a fluid chart, so just have a quick look round and see what their output has been for the last few hours to see if you can get an idea of a trend. Lastly, you want to go and see your patient. Have a look at their mucous membranes inside their mouth to see if they look like they're dry. If their tongue is dry, that's a good suggestion that they're dehydrated. You want to assess skin turgor as well, because that can tell you whether or not someone's dehydrated. And most importantly, ask your patient, do they feel thirsty? If they've got a catheter, then you can have a quick look at the catheter and see if the urine looks dark. That might suggest that they're also dehydrated. So the first situation in which you need to give fluids is as resuscitation fluids. Resuscitation fluids are given to patients who are so intravascularly deplete on fluid that they're starting to get hemodynamic compromise as a result. So you'll probably see tachycardia in the first instance, the heart rate going up, and then you'll probably see a drop in their blood pressure to correspond to this. If someone's blood pressure drops below 90 systolic, it's a good indication that they're very intravascularly deplete and they need resuscitation fluids to get their blood pressure back up into a safe range. To give resuscitation fluids, you want to pick an isotonic crystalloid solution, preferably plasmolite, but some centres may still be using Hartmann's solution, or in a pinch, 0.9% saline. You want to give 250 to 500 ml as a bolus as fast as you can. Most patients can tolerate a bolus of 500 ml for resuscitation. We're trying to get that blood pressure up nice and quickly, so we want to act nice and quickly. If you've got someone who's a little bit frailer, a little bit older, or they've got heart problems, kidney problems or liver problems, you might want to be slightly more cautious with your fluid resuscitation and try boluses of 250 ml instead, just to give yourself a little bit of time. Give your bolus, go back and reassess your patient. Has their blood pressure come up? Has the heart rate come down? Do they look and feel better? You might even see an increase in the output of their urine if they've got a catheter. You want to keep giving fluid boluses until you've got your patient back into a safe area. So you can give 500 ml. If that hasn't worked, give another 500. You can do this up to a maximum of 2 litres, and at that point you probably need to change what you're doing. For patients who are shocked, they may need to be given vasoactive support, so you might need to contact critical care, but get your registrar down to see that patient if fluid resuscitation is not working. In some situations, like bleeding after trauma, your patient might need blood. So think about this early, get a group and save off and send it to the blood bank. Some patients are also just really dehydrated. If you think about the old ladies that have fallen and been on the floor for a few hours, potentially overnight, they might be really intravascularly deplete. So again, get your registrar down to see them, make sure someone else has clapped eyes on that patient, but they may just need a little bit more fluid. Next, we're going to talk about fluid replacement. So fluid replacement is for people who've got ongoing losses of fluid that you need to compensate for by giving them fluids intravenously. The sort of situations this can happen in is people who've got D&V or intestinal losses. For example, pancreatitis, or other situations like burns where there's a lot of fluid loss. In these situations, you've probably already resuscitated your patient and got their blood pressure back into a safe range, but they've got ongoing losses of fluid that you need to compensate for. So in that situation, you want to get a bit of an idea of how much fluid they're losing, which probably means they need an accurate fluid balance. So losses such as vomiting, diarrhea, or fluid losses into drains is documented on a chart. They need regular fluid reviews, probably every 6 to 8 hours, and you need to ensure that you're giving a fluid that is appropriate for replacement. If someone's got a lot of GI losses, then 0.9% sodium chloride is the preferred fluid to replace with. You also want to think about your other electrolytes. For example, if someone's vomiting, they're probably going to need potassium replacement as well. So think about doing U's and E's 1 to 2 times a day just to make sure that you're adequately replacing all the electrolytes this person needs. So we're going to talk about maintenance fluids last. Maintenance fluids are for people who can't take fluid or nutrition by mouth for whatever reason, whether that is due to nausea and vomiting, fasting for theatre, or because their swallow's unsafe. Maintenance fluids are different to resuscitation and replacement fluids in that they're given much more slowly, and so we can use hypotonic solutions. The main fluid that we use is 0.18% sodium chloride with 4% glucose, and most people will also need 0.3% potassium added to this. This preparation aims to give your patient their sodium requirement, glucose requirement and potassium requirement over 24 hours. They come in litre bags and you can prescribe them at a rate that's appropriate to your patient. Remember that your average patient will need 30 ml of fluid per kilogram per day, so that's 2,100 ml for your 70 kilogram man. When you're calculating somebody's maintenance, you need to think about all the fluids that they're going to get. So have a think about whether they're getting antibiotics from the nurses that will contribute towards the daily amount of fluid taken. Think about NG feeds or PEG feeds that will contribute to their nutrient, electrolyte and fluid intake. And remember to look for any signs of excessive losses that will need replacement as well. Maintenance fluids basically provide your patient with the bare minimum. They're enough to keep them alive, but it's not the same as having a normal healthy diet. It doesn't give them elements such as magnesium or phosphate, so these may need to be replaced additionally if your patient becomes deficient later on. As a general rule, if your patient is on maintenance fluids, they should probably have bloods done fairly regularly, probably once a day, just to make sure that those electrolytes are not becoming deficient. The glucose component of your maintenance fluids will stop your patient from developing starvation ketosis, but is not enough calories for them to survive off the whole course of the day. So it's really important to get your patient back to eating and drinking as fast as possible. Once your patient is able to eat and drink, or you've established an enteral route, you should stop your maintenance fluids and switch to that route instead. It's much more physiologically normal to take food and fluids through an enteral route than to try and give it IV long term. For people who long term will not be able to take enteral nutrition, they may end up on TPN, which is total parenteral nutrition. This is designed to give your daily fluid, fat, glucose and electrolyte replacement over the course of 24 hours. The bags are made up for each person and they're very individual, so you'll need to work closely with your local biochemistry department and your pharmacy to ensure that you're getting appropriate TPN for your patient. TPN is a very special circumstance, so always do this under the guidance of your registrar and your seniors to make sure you're doing the right thing for your patient. And remember, we're trying to get them back to eating and drinking as soon as possible. Giving IV fluids can get complex really quickly, so always check with your seniors if you're unsure what you're doing. Regularly assess your patients, see them in person and take bloods to make sure you're doing the right thing for that person. Hopefully that's given you a bit of an overview of the world of IV fluids. Make sure you like and subscribe to our channel so you never miss a thing.